Hey everyone, my name's Ryan, and that's Bramble. And on August the 30th, 2025, I had a prostatectomy after being diagnosed with prostate cancer on July the 2nd, 2025. You've probably heard all the boring statistics, but I wanted to make this video to show you what it's really like. The good, the bad, and sometimes the slightly embarrassing. This isn't just about me, my story. It's about raising awareness, the effects on your family, sharing a laugh, and hopefully encouraging more men to get checked. After all, guys, it's just a cheeky finger that could save your life. This is my personal journey from a simple blood test to life on the other side of the big surgery. So grab yourself a tea, coffee, a beer, a whiskey, and join me on my journey.
Woke up at 3, gotta go again. This tiny gland keeps messing with my day again. It's the size of a walnut, but it runs my life. Big decisions about the surgical knife. This is prostate cancer, from diagnosis to recovery. Me chose the patient, the fighter, he took the biopsy hit, still standing proud. Turn it up now, this is his crown. Prostate cancer, we're facing it with a grin. Stay tuned, the journey is about to begin.
Hello and welcome to my prostate cancer awareness video diary. You may notice that the video actually starts from the day before my surgery. Now, the reason behind that is that being what I call a young man, be diagnosed with prostate cancer at the age of 48, I suddenly thought that it may be useful to go through my journey and to explain a few things, signs and symptoms, perspective from a partner throughout my journey as well, just to help other people understand prostate cancer, signs and symptoms, and what you may have to go through if you happen to be diagnosed with prostate cancer yourselves. It is a very light-hearted video, I must admit, and there are some scenes in there which are quite amusing. So I just wanted to give a quick breakdown of a timeline very quickly. I won't keep you too long. So really it all started about October 2023, in fact, when I first noticed that I was getting up in the night, not all the time, just now and again, to go for a pee. And I just thought I was getting old. I thought, oh, just getting up for a pee. Everybody says it with my friends, oh, you're getting old, getting up for a pee. And I looked into it, started to take pumpkin seed oil, took pumpkin seed oil, supplements, magnesium and zinc, I think it was. Apparently it helped, and it actually did. After about a week, I stopped getting up in the night, but in the morning I was absolutely busting. Then came November time. I had blood in my semen. Now that was a bit of a, whoa, what the hell's that kind of thing? And that was a wee bit worrying, but after a few days, it cleared up. Nothing else. It was all fine. And the other thing I did notice was a drop in the power of my ejaculation. It wasn't quite as powerful as it was. And this kind of felt like it happened overnight as well, oddly enough. But the blood thing didn't happen for another 6-8 weeks or so. It happened again, and it went away after just a couple of days. So it was very sporadic. It wasn't all the time. And then eventually, over time, I went to April 2024, went to the doctors, the GP, and they thought it was a infection. They gave me some antibiotics, took some antibiotics. It cleared up. I mean, it wasn't there anyway, to be honest. It was just very sporadic anyway. So took the antibiotics. A number of months later, about 3 months or so later, it happened again. And then it didn't happen again until March of this year. I went to visit my grandfather for his 100th birthday, and my cousin had just been diagnosed with prostate cancer, and one of his symptoms was blood in the semen as well. So the day that I flew back home, from London, I went to see the GP and I had a prostate examination done, and that is when he felt a small nodule. He didn't seem to think it was anything bad. He said it's probably from the infection you had last year, etc., etc. I'll get you to see a urologist. So luckily enough for me, I'm very fortunate that I have Bupa private medical insurance. So I got to see a great urologist down in Glasgow, Braehead, at Rossall Hospital. Really lovely guy, and he checked me again. He also felt the nodule, and he took my PSA blood tests there and then. Now, interestingly enough, he said because of your age and your PSA that's been done recently was only 1.5. Now, 1.5 is extremely low, just so you know, folks. If your PSA test is very high, like my cousin's was in the 20s, I think 26 or something crazy, that's not a very good sign. So he said, I don't think it's cancer. So he said, I'll get an MRI done for you just in case. Went for an MRI scan a number of weeks later, and the MRI came back and they said, yeah, we better get a biopsy done just in case. So back down to Glasgow, I went to Ross Hospital with Dr. Dan Ho, a really lovely guy, and he did the biopsy. He went through the scans with me and he said, yeah, we're just going to take this just in case. Results 2 weeks after that. July 2nd, I had the phone call, which I'll explain in another part how I actually received that news, which is a bit strange. And yeah, so July the 2nd, I got diagnosed with prostate cancer, which was quite a shock, to say the least. So the first few days were very, very hard. I had to work the next day. I'm a tour guide, and I had to pick up passengers the next day and spend 2 days with them, so it was very difficult. Anyway, got booked in for my surgery and on August 30th, 2025. So what you see from the start of this video is actually me going in the day before, the 29th of August, for my genetic blood tests, which nurse Dawn Stewart, she goes through and she explains what it's all about. So that will be coming up shortly. And the next day was my surgery. So the video starts from my blood test. The reason why I wanted to put this video together was because I'm such a young person to get this. And it's scary. I'm not going to lie, it was scary when I first found out. But I wanted to try and put the word out there regarding prostate cancer in men, because it's becoming extremely common. And it seems to be getting even more common for people who are slightly younger than what we think is an old man's cancer, which 60-year-olds and upwards seem to get, but people younger are getting it. My cousin is 57, I'm 48. Another friend of mine, he had it as well, and he's very early 50s, and it seems to be very common. And there needs to be some sort of screening in place for men, because there is no screening apart from a PSA blood test. However, that does not necessarily show that you have cancer, as I found out, which was my PSA results were 1.5. So I'm going to shut up now, and I shall let you enjoy the rest of this video. And I will pop up now and again and just give you some background information about various different things. So I really appreciate you watching, and please share it around. We need to raise awareness about prostate cancer and to get the message out there and to get people checked, get men checked. If you're afraid, just go and get checked. It's really not a big deal, and it could save your life. So please, guys, if you have any of those kind of symptoms I had, just go and get checked. You need to get checked. It's really, really important. And if I can save one person's life through this video, it will make me super happy. And take care of yourselves and enjoy the video. Thank you very much for watching.
Right, so you know why you're here today is to get a genetic blood test because you're obviously a very young man with a diagnosis of prostate cancer. Usually patients are maybe in the early, young is considered really up in your 50s. So after that, we accept that cancer is a diagnosis of older people. So we don't really automatically do this unless there's a strong family history. For you, because you're such a young man, we want to test your blood to see if you've got a genetic mutation. And we're looking for BRCA1 and BRCA2. And these are genes that are very commonly associated with breast cancer. You maybe hear about it in the breast cancer setting, ovarian cancers, but also in the prostate cancer setting.
Okay.
So the reason we want to do this is to see if there is any mutation there. And from your point of view, the impact on your life, if you like, for this is if you've got children, you'd probably want your children to know so that they also can get genetic counseling maybe at some point with the view to getting tested themselves.
Okay.
And also another reason for doing this is because if in the future you did have any issues with the cancer recurring again, it also gives us an idea if you're positive, if you would be eligible to receive certain drug therapy that would also be helpful for you then. So it's just about gaining information essentially at the moment. And that's why it's important. We're not going to do anything with it. And it's most likely going to be negative. Probably about 5 to 10% of patients who have this done will be positive. So it's very low percentage. We're not really expecting it to be, but we have to do it.
Yeah.
So that's the rationale for today.
I believe my cousin was negative when he had his done a number of months ago.
Okay.
Yeah.
So that's a good thing.
Yeah.
And as I say, it's a small percentage of the population. So we're just going to take 2 small blood bottles from you.
Okay.
And these will get processed in our lab. And it probably take about 4 weeks-ish to get the results.
Alrighty. I've got good veins as well, dog.
Good.
Look at that.
Good. It's winking at me. It's winking at
If you
me.
miss that, you need fired.
That's right. No pressure. No pressure.
And stick it through. Stick
Yes.
it through that one that was already done the other day.
I know, I'm literally almost looks like I'm going in the same pond, but
Yeah. Right, everybody, I'll better look away because
Yeah.
I don't like needles.
that's fine. You look away.
I'll just look away from that. You won't take away.
You don't want to know the answer. Look away
I'll
now.
try not to. Oh, I take away, but I like to have a little chat or something.
That's good. Do you want to talk about the weather? It's not going to be good this weekend.
It's and the crappy traffic on the way down. It took 4 hours to get down there. It was done in 3.
Oh, I know. That's a long journey today.
Yeah.
Well, you've been generous with your blood, which is lovely. Thank you.
I know you're welcome.
Easy peasy. I'm at squeezy.
Yeah.
That final blood test was the day before. Knowing what was coming was tough. You try to be brave, but the nerves are actually real. But once you're walking through those doors, that's you committed. It was time to hand the whole problem over to the experts. For me, the expert was Professor Imran Ahmad. I wanted to ask him everything, not just about the operation, but about prostate cancer in general. I'm not gonna lie, I was scared, but it was time.
Welcome to Professor
Imran Ahmad.
Imran Ahmad. Now, this gentleman basically saved my life yesterday, pretty much, which I'm very, very grateful for. Can you give me just a wee rundown of the surgery that you're getting? Because it's quite special, is it? It's not like an open, cut me open kind of job.
No, so you were referred to myself by a colleague who just fortuitously, for something else, had picked up that your prostate maybe felt a bit abnormal, got your scan, subsequent biopsy, and then I think the kind of diagnosis was made of localized prostate cancer and the different treatment options. One of which was surgery to take out the prostate, which you chose. And the way we do the operation is use the Da Vinci system. And essentially it's a robotics master slave system. So I sit on a console, I move my hands in some kind of essentially kind of handset. When I move that the robot will then move the arms, laparoscopic arms inside you. And through kind of 4 robotic arms, I essentially took out your prostate, disabled all the nerves, the control erections, joined you back together, and put suprapubic catheter in to drain the bladder, and then closed you all up.
So when you've taken that prostate out, is that going to be like with myself? Are you sending that away as testing?
Yeah, so that prostate, if it's not in London just now, it'll arrive in London tomorrow, and the hospital kind of use the pathology lab down there, and what will happen is the prostate's in a farmland just now to keep it fixed. Go down there, and the first thing the pathologist will do is take it out and they start chopping it into sections, and then from that they'll make slides that they can have stained, and then the pathologist will start to look at different things. They'll look at, before they've chopped it up, they've weighed it, the size. They look at grossly, is there anything grossly abnormal coming out of it, which I know there isn't, because I looked at your prostate after we finished. And then when they chop it up, they will look at the kind of Gleason grading, which is a grading of how aggressive the cancer is. They will look to see how close it is to the edge, so the margins.
Yeah.
And they'll also give you a kind of T stage. Is it still in the prostate? T2s that come out, TCA.
Right, okay.
But based on everything we know so far for yourself, I would hope it comes back the same, which we know it's all applied to the prostate. Right, that's a bit floating early.
Yeah, which is good. And I know that when Dr. Dan did the biopsy, he kind of said, when he told me, he said, I think we came across this almost by accident.
Yeah.
Because obviously seeing the urologist in Braehead, and then him just said, we'll get an MRI just in case.
Yeah, because your PSA was normal, so that's where it comes into the dilemma about PSA screening. So if you were just screening you based on your PSA, you would have been discharged. Your PSA was less than 2, so it's normal for your age.
Yeah.
Which is why we know, and why screening based on PSA hasn't gained a foothold and isn't happening, because it's not a great tool, because it does miss cancers like yourself.
Yeah. Because that if it had been left, I don't know how long it would have waited until it would have actually shown a high level PSA.
Yeah, it's difficult to know that some men it's already broken out the capsule and spread to lymph nodes, and the PSA is still normal. So it's difficult to know.
So there's no other, isn't there any tests? Is there any tests on the horizon that they could sort of say?
Some genetic tests coming through, but I think the most promise is in men, if you can put them through an MRI scanner very quickly and screen them that way. So men who are eligible of an age or a family history or ethnicity such as Afro-Caribbean men, we know are increased risk. So maybe have a screening program that's based on MRI, because the MRI was what picked you up, and it's the most accurate tool that we have. It's very good at telling us if there's clinically significant disease there or not, or there's nothing.
Yeah, sure. Do you think prostate cancer has become a lot more known? Do you think it's become more common, shall I say, because of people being more open sort of to it?
Yeah, probably a couple of things going on. So we know all men get prostate cancer if they live long enough. So people are living longer, healthier. So we're picking it up more. Yeah, certainly awareness is much higher than it used to be.
Yeah.
So in the past, you can imagine 30, 40 years ago when people died, they say, well, what did they die of? Well, we don't know, they just died. But as now, I think very rarely does that happen. Everyone has a diagnosis right the wrong way. And with the PSAs, the scans, a lot more men are being picked up. And also, I think with awareness like this podcast, or even like celebrities like Chris Hoy coming out, I think men are talking about things more, and I think, right, okay, maybe I should get my PSA checked.
Yeah, exactly. Because when I found out, and I've told everybody, not because I want sympathy. Yeah, I think it's because of me, because of how I am. I'm very open about everything, my feelings, and but I tell them, and the first thing they say, what are the symptoms? And I go through and I tell them what my symptoms were, which was a loss of getting up in the night, which was really hard, and then the loss of power in my ejaculation, and blood in semen. Okay, which is one of the blood in the semen one was also what my cousin also had as well. So I don't know whether that is coincidence that he also had prostate cancer and he also had the blood in semen, because I'm not sure if that's a popular symptom.
So it's interesting. So most prostate cancers, what are localized, have no symptoms, if someone does have blood in the semen, then one of the things that we want to exclude is a prostate cancer. But so prostate cancer can present with blood in the semen, but most of the time, blood in the semen isn't prostate cancer, if you see what I mean.
Right.
So 99 times out of 100, if someone's got blood in the semen, it won't be prostate cancer. But if someone does come up with blood in the semen below, that's one way it can present. So we do a PSA and MRI often.
Yeah, yeah. Which was quite odd. Like you said, my PSA was fine.
Yeah.
It's been fine for the last number of times I had it done. Yeah. So I've had the PSA done maybe 3 times over the last year or so.
Yeah.
And I just think that April last year when I went, so April 24, when I first went to see the doctor about this, and that if they had said, right, we're going to get you for a biopsy, that's the only time they would have found it. So it's really difficult to diagnose yet, I think. And I'm just doing this, the whole reason why I wanted to do this video and a chat with yourself and also a chat with my cousin, hopefully, and my friend on Sky, just had it, just to make people a bit aware. And I think guys don't like to talk about these things, about their bits and pieces.
So it's like, I think certainly they don't like to talk about it, and culturally as well, some cultures, a lot of shame associated with it, and it's, there's no getting away from it. The prostate is there, that a lot of the ejaculate you have, the fluid comes from the prostate, and it's there to provide nutrition to the sperm, that it can survive in the woman long enough to fertilize the eggs. And then a lot of the side effects from taking out the prostate affects erections, affects continence just where it is.
Yeah, and I guess that would make people not want to talk about it.
Yes.
You know, that's part of being a man, is getting an erection. Exactly. To reproduce. And if you can't do that, then you kind of feel like you're less of a man or something. But I don't know, like you said, the nerves that you obviously spared the arm where you took mine out, you know, hopefully, fingers crossed. Yeah, we'd be good.
No, hopeful.
Yeah. So it's good to know. Yeah, good to know. But I just want to get it out there just so people can know more about it and know more about what you do, as in the robotic surgery, because I had no clue about that.
Yeah.
Literally no clue at all. So it's good to know.
I know it's unfortunate the way that you have found out about it, having to have it done, but I think for you, given your age, your mindset, I think the alternative of kind of radiotherapy, hormones, I think that for me, and the oncologists as well often say to younger men, I think maybe surgery is a better option, because the worst that you will feel is when you wake up from the surgery, and then today you're looking great, doing laps, and if you didn't live in Inverness, you would probably be sitting at home by now. But it's because you've got a distance to drive. Let you home tomorrow, have another 9 just to make sure you're okay.
So it's no, it's been brilliant, and it's been very interesting as well to chat with you and just find out a bit more about it as well, and then hopefully we'll spread the word a wee bit. Get it out there, and if you ever get prostate, he's the man. He's the man. But no, I don't know if Laura has any questions.
Yeah, no, it's a shame that there aren't any obvious symptoms that, you know, you can sort of know yourself. And like you say, the PSA can not really tell you much sometimes, unless it's, in your case, it was low, but you had prostate cancer. So I guess the only other thing I was thinking is that men, are they maybe afraid for like the DRE, the prostate examination? Do you find that with men, like, do they have that fear of going to the doctors? I don't want to get my prostate checked.
Yeah, no, it's a lot. It's very common, because a lot of men, that's why they won't go or talk about symptoms, because they're worried about the digital rectal examination. And actually, the colleges have come out and said, if for prostate screening, if you're actually thinking that someone's got prostate cancer, they've got a high PSA, you shouldn't even bother doing the DRE, you should send them straight for MRI. So we're trying to push that across. So certainly if I see men that have come to see me at clinic that have got a high PSA, I will say to them, look, I'm not going to examine your prostate because I'm going to send you for an MRI anyway. It's men that have got symptoms, or say, for example, blood in semen, but the PSA is normal. They're the ones that I will examine and do a DRE on, because they might not be patients that send for an MRI, so I'll have a feel. But I think the DRE, unfortunately, does put a lot of men off. And I think for a lot of urologists, it's kind of fallen out of favour just because we've got the MRI. If it's so much more information, we know that maybe we should be doing it less than we are, and encourage more men to come.
Yeah. There's I think there's a lot of worry for men just even go to the GP because they just get a cheeky finger on them, and and they won't talk about it. I've got a friend of mine who's like, I said, mate, just do it. It takes like 5 seconds, and you're done.
Yeah.
It's like, it's a big deal. And I think they get a bit embarrassed about that.
No. But I think, and you're right, a lot of it is embarrassment. And talk about it just fees.
Yeah, pretty much.
It's just such a shame though that there's not, like a screening for it, because it is so common and it's scarily sometimes don't have symptoms. Whereas, breast cancer, you get your mammograms at a certain age for women. You've got your cervical cancer screening, your bowel cancer screening, things like that. So yeah, it's quite scary that there's not that screening, isn't there?
I think it will come. There's a few trials that are starting to look at different types of tests for screening based on genetic tests, PSA, MRI, and just to kind of inform what is the best way, the most cost-effective way to, if we are going to start a screening program, ZK, because it all comes down to money as well, doesn't it? Can we afford it?
That's the problem, because they're not going to say, oh wait, I think you have possible prostate cancer, but it's going to cost us so much money to go and put you through. And how many people are going to go and have an MRI scan and they call that is fine? But then they're probably thinking, well, we're going to waste all that money sending all these people for AI that they didn't really need. So,
and already most MRI scans that happen in the NHS, I think, are prostate related. You can imagine if every man over 45 with a family history, or they're Afro-Caribbean, or a man off the street who's 50 has an MRI, the system would collapse.
Oh yeah.
It's not possible, which is why we need to do some sort of smarter screening.
Yeah.
Whether it be with kind of genetic tests before to kind of identify men, okay, that so that they would benefit from an MRI, they should be put forward for an MRI, and then someone else say, okay, that's fine now. Risk of prostate cancer is very low, they don't need to go for MRI. So we almost need a kind of triage test before they go for MRI, unless we just manage to make the MRIs very quick and very cheap and have them in essentially in kind of Sainsbury's car park, similar to get a mammogram spin.
Yeah, that's what I was just thinking. Just have a centre, prostate centre, where you have a bunch of MRIs, and everybody basically lines up to go in that long hair. A bus shower.
Yeah, no, definitely.
Line them up, get them in and out. And I think that's probably your best way. I think, yeah. Right.
No,
But in the meantime, any sort of symptoms, urinary, sexual symptoms, anything like that, it's worth getting checked.
yeah, I think if anyone is worried or they've got that at the back of the head about prostate cancer, they've got family history, they're Afro-Caribbean, they're of the age, just go and see your GP. Yeah. And then the GP will hopefully kind of start the ball rolling in terms of one, assessing your symptoms, checking if you've got prostate cancer, and most importantly is getting your symptoms better, whether they're urinary or sexual.
Yeah.
Because a lot of men, even if he's got prostate cancer, suffer in silence with a lot of work with sort of sexual symptoms, and they don't have to.
Yeah.
Lots of different treatments available now.
Yeah, exactly. That was good.
And then when I had my surgery, Ross Hall Hospital on the 30th of August. Bloody hell. That was pretty savage, actually. I was actually quite worried. I even transferred and gave you access to my bank accounts because I thought something was going to happen to me.
What, during surgery?
Yeah.
Did you?
Yeah. I was shit my pants.
I
thought something was going to happen to me, or they were going to find something else, or I was worried.
It's quite amazing because you might not be able to see this, but I have how many's there? We've got 1, 2, 3, 4, 5. I think is there another one down? There's another one down there.
6. So essentially, that's where the camera goes through.
Oh, right.
My right hand is here, which I control the scissors to do cutting. And then when I'm stitching, I use that instrument. This is my left hand, and this fourth arm essentially is a kind of retractor arm. You kind of make the space and push things out the way.
Yeah.
Alison, my assistant that helped me with the operation, this is a smaller port where she brings the sucker through to suck any blood and help the retraction.
Yeah.
And this is the big port where Alison will bring in clips, the sutures, and also the open this up at the end to take out the prostate.
Okay.
So that's why that's the biggest one that most men find that a bit more painful.
Right. Okay. So so you by going through there, you've cut the prostate away, and then you kind of pull it out of that hole.
Yeah, essentially widen it a bit, pull it out because it's in a bag, and then just stitch the sheath and then close the skin.
Yeah.
For the rest of the wounds, because they're so small, we just close the skin. That one we close the slightly deeper layer as well to make it a bit bigger to get the prostate out.
Oh, right. Okay. Okay. So when you've taken that prostate out, you've disconnected the urethra. Is that right?
Yep. So essentially, you got the bladder, and the prostate sits just below the bladder as a kind of one kind of organ almost, they're kind of joined, and then the urethra actually runs through the prostate. It's called the prostatic urethra. So to get the prostate out, we need to cut the bladder neck. So cut the prostate off the bladder, and then you've got the prostate sitting there with a tube, a hole through it, and that's the urethra. And then we can identify the front of the prostate, the apex, and cut it there. So your prostate comes out, and it's got a bit of urethra running through the middle. But then what you're left with is your bladder with a hole in it, and your urethra, and essentially we join those two together.
Okay.
So then with time, that's what you'll pee through naturally,
Right. Okay.
rather than through a prostate, because that tube is gone with the prostate.
Yeah. So when you stitched that to the bladder,
Yeah,
like you recently,
yeah, exactly.
physical stitches.
Yeah.
Yeah.
So we use two kind of essentially barb stitches, and we start at kind of 12 o'clock.
Yeah.
And then we just work to the top and tie it together. So kind of tying two kind of cylinders together.
Right. Okay. Okay. It's quite amazing.
Yeah, I suppose it is when you think about it and
Yeah.
what we can do. But
Yeah. So obviously it's a lot less invasive because in the old days before the robots were
yeah.
I mean, what was the procedure for that? Was that cutting you open?
Yeah, so essentially, when I did my training in the west of Scotland, the only way we would be able to do prostatectomy is open. So essentially, it'd be a cut from just below your belly button to your pubic bone. Patients commonly would have a catheter and a drain in. They'd be in a high dependency unit for a couple of nights, and some of them would be in hospital for up to a week. And they used to have a lot of problems with bleeding because it used to bleed a lot more during the operation. And in terms of the continence erectile function, it was never as good. And it was just a really difficult operation to do because you can imagine you're down a deep, dark hole.
Yeah.
And then you're kind of, essentially we used to call it a kind of one-handed, one-eyed operation because you only could get one hand in. And you could actually only see the prostate if you're kind of looking like that.
Oh, really?
Yeah.
So you've done a lot of those types of
Not as a consultant, as a trainee, I assisted quite a few and did a few, but I would never dream of kind of going back to do that. This has made it so much easier, both for the surgeon and the patient.
Yeah, yeah. So the unit you're sat at, if you've got like an Xbox controller.
So some of the newer ones actually you have a controller you control, but this one essentially has a couple of bits for your fingers. So your thumb goes in one and your middle finger in the other. And by kind of opening and closing it, the jaws of the instrument open and close. And you can imagine you can move it up and down and the wrist of the instrument moves.
How cool is that?
No, it is really cool.
Yeah, it's very cool. And to those the big hands that you use, are they more ambidextrous or whatever, more supple than the human hands and a lot smaller?
A lot smaller, probably not as kind of dexterous because you can imagine your wrist has got a lot of movement.
Yeah.
The wrist of the instrument can go up and down, left or right, but it can also kind of you can rotate it and move it into different angles. So I suppose it's difficult for me to explain because I've been using it for so long. It almost seems like second nature. So I had to talk about it. Yeah, okay, actually, what do I do? How does it work? Yes, it's you go and sit down and you start controlling it.
Yeah.
It starts kind of working and moving.
Yeah. So on those, is it a blade that cuts or is it laser?
No, so there's different instruments. So when you start the operation, you've got scissors with electricity on them, cautery. So you hot scissors essentially. So when you cut, you can use the energy to stop bleeding. Okay. And then when I'm stitching, it turns to almost a little kind of clamp, and you go hold it to hold the stitch too. Mm-hmm. So you can actually change the instruments as you're doing it.
Oh, right. Okay. Amazing. This is super cool. Imran, thank you so much.
It's a pleasure. It's been worth doing this and looking after you.
I know. This man, he saved my life.
No, we're all. No. That's, no. It's good.
very gently put a swab there and say to you to count to 10.
Oh, you bugger.
But at the time you've counted to 10,
Oh, that was a good job, that was.
by the time you've counted to 10, I've removed the catheter and I've put,
Don't make me laugh. It hurts.
and I'm pressing that swab on there.
Woo.